Welcome to the American Society of Echo E3 lecture series. My name is Lucy Safi and I'm Director of Interventional Echocardiography at Hackensack University Medical Center and Chair of the ASE Emerging Echo Enthusiasts, also known as E3 Special Interest Group. This special interest group provides an opportunity for early career physicians, sonographers, and trainees who are interested in echocardiography to present, interact, and discuss echocardiographic topics. Each lecture is formatted as a 30-minute didactic lecture followed by a panel discussion. On our panel will be 2 moderators and an expert in the field. During the discussion section, the panelists will also answer audience questions, so please enter your questions in the Q&A box below. This virtual lecture series will be recorded and later available online on the ASE E3 website. To join E3, log on to your ASE account, click Update My Profile, Specialty Interest Groups, and then choose Emerging Echo Enthusiasts. Today's topic will be Hypertrophic Cardiomyopathy. It is my pleasure to introduce my co-moderator, Dr. Ahmed Masari. Dr. Masari is a non-invasive cardiologist and the director of the HCM Center at Oregon Health and Science University. He received his internal medicine degree from the Cleveland Clinic, completed his cardiovascular disease fellowship and advanced imaging fellowship at the University of Pittsburgh before joining as faculty at Oregon Health and Science University. Thank you for joining us, Dr. Masari.
Thank you, my pleasure.
Our expert today is Dr. Dermot Phelan. Dr. Phelan is the Medical Director of Cardiovascular Imaging, Director of Sports Cardiology, and Co-Director of the Hypertrophic Cardiomyopathy Center at Atrium Health Sanger Heart and Vascular Institute. Previously, Dr. Phelan established and ran the Sports Cardiology Center at the Cleveland Clinic. He is the team cardiologist for the Carolina Panthers and a cardiology consultant for the National Football League Scouting Combine. Dr. Phelan was the first author on the original work which described the pattern of apical sparing of longitudinal strain in cardiac amyloidosis and is the graduate of the ASE Leadership Academy. Welcome, Dr. Phelan. It is my privilege to have you with us today.
Thank you, Lucy. Great to be here with you, Madeline, and Ahmed. Looking forward to some great conversation.
Our guest speaker today is Madeline Jankowski. Madeline is the lead cardiac sonographer of education at Northwestern Memorial Hospital in downtown Chicago. Aside from education coordination and QA oversight, Madeline continues clinical scanning in patients across all pathologies, including transthoracic echoes, stress echoes, and intraprocedural imaging for alcohol septal ablation procedures. She is an active volunteer in the ARDMS and vice chair of the Adult Echo Board's Exam Committee. She also holds positions on multiple ASE committees, task forces, and is part of the second cohort of the ASE Leadership Academy. Welcome, Madeline. We look forward to your presentation.
Thank you, Dr. Safi, and everybody for joining us, and to the ASE for having me tonight. And today we'll be discussing some echocardiographic features of hypertrophic cardiomyopathy. And my disclosures are at the bottom. So our objectives tonight are to first overview what is hypertrophic cardiomyopathy. And then we'll really dive into some echo findings for HCM with a focus on how to evaluate the hypertrophy, the obstruction, and then any secondary findings. We'll also go through a few of the invasive therapies for hypertrophic cardiomyopathy. And we'll also talk about some of the pathologies that may mimic HCM and how to be aware of those and to differentiate them. Hypertrophic cardiomyopathy is the most common genetic myocardial disease, and it's estimated in about 1 in 500 people that have HCM. This disease is characterized by the cardiomyocyte hypercontractility, left ventricular hypertrophy, myofibrillar disarray, and myocardial stiffness. And I'd like you to take a look at these pathos slides down at the bottom and really look at this normal cardiac muscle where we see kind of these smooth lines that are all parallel to each other. And then when we look at the slide for hypertrophic cardiomyopathy, I really feel like I can appreciate the disarray, this myofibril disarray, and the kind of intricate ways that this muscle is developed and how it could be stiff and fibrosed. And how we diagnose hypertrophic cardiomyopathy is when we look at LVH that's greater than 15 millimeters. But we want to see if there's any underlying afterload increasing conditions like chronic hypertension or aortic stenosis or other genetic conditions that may cause hypertrophy. Without any of those, we may suspect HCM. HCM can be also obstructive. So when we talk about HOCM, that O is for obstructive, but it can also be non-obstructive, so they're not mutually exclusive. So when we first start to talk about hypertrophic cardiomyopathy, hypertrophy is the first thing that we think of. And the two things that we need to determine are the location and the severity of the hypertrophy. When we talk about location, the ACC has categorized hypertrophy into 4 main groups. And I think the 2 most common that we see are the sigmoidal HCM, as we see at the bottom left here. So this is when you have that little knuckle bulge, the basal septal hypertrophy. And that can be seen in patients with HCM, also in elderly patients. Second, we have this reverse curve HCM where we see especially this asymmetric LVH and the septum being really thick and actually going into part of the left ventricle to make it more of a crescent shaped. Then we have apical HCM, which is about in 10% of the HCM population. And this is predominantly seen in Asian populations. And we can see up at the apex that we see that kind of focal hypertrophy and really well seen with echo contrast. And then finally, the neutral HCM is another 10% of these patients and really just looks like concentric LVH. And then once we determine the location of the hypertrophy, we want to actually measure it and tell the clinicians how big is this septum or wherever the hypertrophy is. So when we take a look at this parasternal long axis image on the top right here, we want to make sure to only measure the left ventricular wall thickness and exclude the right ventricular wall thickness. So in this particular patient, I've drawn arrows and you can kind of see a divide between the right and left ventricles. And it's really important to only include that left ventricular thickness and not the right, which could be just wall thickness or maybe the moderator band. The second thing we want to look for is any obstruction. And like I said before, HCM does not need to have obstruction to be considered HCM. But when it is, we want to see where is it and what's the severity. But first, before we talk about that, let's understand the mechanisms of how this obstruction happens. And we'll talk about SAM, systolic anterior motion. And we're mostly talking about that of the mitral valve. So we want to look to see what part of the mitral valve apparatus is being pulled into that outflow tract or into anywhere that could cause turbulent flow. In this particular patient that we see this anterior mitral valve leaflet kind of crouching on the septum and really making this alveoli narrow. And that narrowing, the Venturi effect, if you've heard that term before, is an increase in gradient because of a narrowing. So as that mitral valve is being pulled into the outflow tract, it is narrowing, causing this gradient to go up and also causing a drop in pressure at that same time. The second mechanism of this obstruction is drag force. So these patients with hypertrophy can have it kind of anywhere in their ventricle, and that kind of obscure geometry of the hypertrophy plus possibly misplaced papillary muscles or displaced papillary muscles may lead the ventricle when it's contracting to have that blood flow go a little bit differently. And if we see this small green picture up at the top left, the force is kind of the way the drag is the friction made by those kind of excess geometry, and it really sucks in the mitral valve and takes the blood up so that it's hitting that bottom of the mitral valve leaflet. And this causes that obstruction. It causes the mitral valve leaflets or the chordae to get into that outflow tract. And now we need to see where it is. And so when we're using pulsed wave Doppler, we can really define where in the ventricle that, that we're obstructing. And so in this patient that has this kind of LVOT, pretty typical SAM, we place a pulsed wave at that LVOT and we see this aliased flow. And I'll just give a tip that we want to change our scale so that it's large enough so that we can see most of the waveform here. But if you change it too much, you might go into an HPRF or high pulse repetition frequency mode. And what that'll do is actually place different pulse waves along your same sample volume line. So it's not actually just looking at the one place you want it to. So just be aware of that when you're changing your scale. Also, just including moving the baseline up so that you can really see this signal, but really what we're looking for is that aliasing of flow. This tells us that there is turbulence in the LVOT. I also then like to go up the ventricle, kind of walk the pulse wave up the ventricle. And this helps you, one, determine that there is laminar flow at other parts of the ventricle, but then there's no obstruction there. So at the mid and at this apical view, we see that there's a little more laminar flow. When we're looking at the severity of this gradient, we want to use our continuous wave Doppler because it's picking up the highest velocities. And really, we want to focus our beam right in between the mitral valve leaflet and that septum. And we want to do this at a few different phases. So at baseline, we will get a nice resting gradient. So what is this patient's heart doing while they're just sitting watching TV? And for this patient, his gradient was 81 millimeters of mercury at about 4.5 meters per second. But then we also want to see what's happening when the patient's moving around and doing things. So we try to provoke a higher gradient. So we can use Valsalva maneuver and really the straining phase of Valsalva to help increase that gradient if there is a provocable one. So in this patient, it increased from 81 to 131 millimeters of mercury. Some institutions use a vasodilator medication such as amyl nitrate, and that helps hold the blood in the periphery. And so there's less preload and it will help kind of bring out that obstruction if there is any. The last thing that we can do to assess this gradient is use stress echo and look at the gradient after the patient has been exercising. And so for this patient, it went up from 81 to 131 to 179 millimeters of mercury. So we can really see the range of how this patient is from resting to stress. A secondary finding that is really closely tied to that obstruction is the mitral regurgitation. And like we said, the SAM causes this MR because the leaflet is actually getting pulled when it's supposed to be together. So I think in these two images, you know, right at the end of systole, you can really start to see that leaflet getting pulled and actually where that mitral regurgitation could come out here. And same within the short axis, we really see a gap there where that mitral regurgitation could come through. And a lot of these, because of the way that it's getting pulled into kind of towards that anterior motion, it will be a posteriorly directed jet. And because this is also, you know, the mitral valve is being sucked kind of in a dynamic way, we think of that obstruction as being dynamic, but the mitral regurgitation will also, it could be dynamic. So this superimposed image is one that I think is really important to see. We can actually see the LVOT signal inside of this mitral regurgitation signal, but both of them look dynamic. So just to be aware that those two can look very similar, and so we have to tease them out. So just some tips for mitral regurgitation. I like to use just a dedicated image, and I'll really try to focus my continuous wave Doppler through the LVOT, but then I really try to focus the beam to get the mitral regurgitation jet so that I can really say, This is what the regurgitation is doing, and this is what the LVOT is. And I think this really helps in, looking at the two and really understanding the pressure gradients within the heart. And so the same thing, I'll do the same thing after stress and put the cursor through to get what I think is the LVOT signal, but then I'll also do a dedicated shot of the mitral regurgitation so that we can help differentiate the two. And I think as an internal control, we can use these jets, these mitral regurgitation jets, plus the blood pressure to help calculate, if we're not feeling like we accurately got the LVOT signal. And I think some of my colleagues will go through that in a little bit. Another secondary finding is an apical aneurysm, and this can be seen in any of the phenotypes of HCM. But this patient has some apical hypertrophy, and when I evaluate these patients that I think have HCM, it almost looks like it's pretty flat at the top there. So I start to suspect, is there an aneurysm there? Is there just hypertrophy? Why can't I see the bottom of that? So that's when we would give some echo enhancing agents. So, but I wanted to point this out. This gives us the same image here, and even though we used contrast, it doesn't necessarily help us see the aneurysm as you have to do imaging techniques with the echo contrast. And so I'll show these pictures. These were taken kind of off axis and really focusing on that apical view, maybe sliding down a rib space and having the patient take a really big breath in. But we can really appreciate that dyskinetic portion of the apical aneurysm, which maybe we didn't as much see in this biplane image. So just talking about apical HCM quickly, apical hypertrophy, we can see it most often best with echo contrast. And really we see it defined, the key point is this spade-shaped ventricle in diastole. We can really appreciate it, especially with contrast. These patients may also have a T-wave inversion on their ECG, and then the apical, the strain may have some low apical or decreased strain at the apex because of that hypertrophy up there. So let's get into some cases. So case one is a 76-year-old male with a gene mutation. He's gene mutation negative HCM, but he's got a provocable obstruction, and he presents with increasing dyspnea after walking up the stairs, but at rest, he's totally asymptomatic. When we start looking at this 4-chamber image, I notice some hypertrophy in the septum here. So that makes me start to think, where is this hypertrophy? I can also start to appreciate some sort of systolic motion of this mitral valve. So we'll take a look at that later. But before we even start to assess the obstruction, I always like to give the clinicians a very clear view of the aortic valve to make sure there is no fixed obstruction in these patients that may also have a dynamic obstruction. So this is just ruling out that he does not have any AS that is with this HCM. And then when the strain was performed, we can see this pretty typical pattern where we see decreased strain in the septum here, where a lot of that fibrosis and stiffness is taking place, and then a little more normal strain in the apex and the lateral wall. So again, we're going to talk about the hypertrophy first. Where is it and how bad is it? And again, when we look at these, the parasternal long axis image to measure this septal and posterior wall thickness, we really want to tease out the difference between the LV and the RV. So again, this patient, you can really see the line that separates the two, but sometimes this could be the RV moderator band or maybe some RV hypertrophy. You can check yourself, once we've measured this and excluded that RV part, you can check yourself by rotating to a short axis and measuring it there as well. And I think that really helps to just look at the two and make sure you're getting the same measurement. And then again, these may be asymmetric or they can be concentric, but I want to just draw your eye to the posterior wall, and this is a trick I use. I literally just scroll through like this to help see where that posterior wall is and to make sure that I'm not going to include any of those chordae or papillary muscles while I'm measuring this smaller posterior wall. So then we're going to look at, is there any obstruction? And if so, where is it? So this patient we saw by 2D echo had some systolic anterior motion of his mitral valve. And we can really appreciate that on the M mode image here. And we can appreciate how much there is. So it doesn't quite touch the septum, but we do see some motion there. And then when I start to look at the severity of this, I drew these lines here because I don't necessarily want to go all the way out the outflow tract. I also don't want to go all the way through the mitral valve. I really just want to see what the gradient is right between the septum and that anterior mitral valve leaflet. So really using your techniques to move that image around to get the beam aligned with this pattern will give you some of your best gradients. And this gentleman, his resting gradient was 18 millimeters of mercury. And then with Valsalva went up to 52. So he did have this provocable gradient. And then just like we did before, we're going to pulse up the ventricle. So starting at the LVOT, we see that aliasing. And so we know that that obstruction is there. And then we have more laminar flow up the ventricle. Then we also want to talk about, is there any mitral regurgitation that comes with this systolic anterior motion? So at rest here, we see he's got some mild posteriorly directed MR. And then I want to make this image a little bigger on the continuous wave Doppler because the sonographer really tried to align the Doppler beam with that posteriorly directed jet. So they turned the ventricle going a little more medial on the patient's chest to really line up to get that nice envelope, and so you can see the bottom of the envelope. Something that I've started doing on a lot of my HOCM patients is I couldn't quite grasp how when we see that the LVOT obstruction goes up when the patient valsalvas, but we don't necessarily see what happens to the MR. And so I started imaging patients while they're doing a valsalva. So here's starting the straining phase. And then we can see that MR gets a lot worse. And so you can tell that that mitral valve leaflet is being sucked even more into that LVOT. And again, getting a nice Doppler waveform of just the MR. And then finally, I wanted to just point out that a lot of your signals may look something like this, where it's something that it could be MR, it could be LVOT, we don't really know. So these are ones that we really need to tease out. Performing a stress echo, we were asked to evaluate the LVOT gradient, MR, and PA pressures with exercise. And so this gentleman had a great exercise capacity he exercised 10.1 METs and just was terminated due to fatigue. So first we took a look at the gradients and the MR. So we saw that his LVOT gradient increased to 4.9 meters per second, or about 96 millimeters of mercury. We also took a color picture of the MR and looked at how much it was, and maybe it increased to moderate. I also, like in this same image, I have both the MR jet and the LVOT. Really good to see both, so that we can really say that these are two different waveforms. The other thing I wanted to bring up is a lot of these stress echoes that are ordered for HCM are going to be, we want to do our hemodynamics first. And so the evaluation for ischemia may be less sensitive when we're evaluating for hemodynamics first. So just be in contact with your attending physician who's reading it, just to make sure you are understanding what is more important in these patients. So let's go on to case 2. It's an 80-year-old female with a mid-ventricular phenotype of HCM who presents with intermittent left-sided chest pain. And when I look at this parasternal long axis image, I start to see kind of this basal septal hypertrophy. She's also got a pretty small cavity, and then some type of obstruction we start seeing here with the mitral valve leaflets. So the first question we're going to ask is, where is the hypertrophy? And so we started seeing it at the basal septum here, but maybe it's a little bit at the apex as well. And do we see any secondary findings here? I don't feel like I can see the apex very well. So the sonographer slid down a rib space and we could appreciate this giant left ear apical aneurysm. And just because we just slid down a rib space, we were able to open that up. And then using contrast, I think we can appreciate that even more, and then also rule out the presence of a thrombus. And then the last thing we want to do is there obstruction? And if so, where is it? And so I want you to take a look at this interesting waveform that looks like a lobster claw. And these two signals are two different parts of this jet. And so I want to walk us through that. So looking at this color flow, we can see some increased turbulence here at the mid-ventricle. But if I pause this and really walk through it, we can see that both of these waveforms are in systole. So this first part of systole is the LVOT, so we can see some turbulence there. So that's that first part, and that aligns with our EKG. And then as I scroll through it more, we can start to see that mid-ventricular obstruction. And so that's that denser jet. So again, if we scroll through, we start to see that first waveform is the LVOT flow, and then the second waveform is that turbulence in the mid-ventricle. And that's confirmed over here by our pulse wave Doppler, where we see the really large midsection pulse wave. So a few slides just on HCM treatment, especially with obstruction. The first is a surgical myectomy, and this is done in the OR, a procedure where they just take out part of this septum that may be causing that obstruction. And it looks like somebody kind of took a bite out of it. So in these patients post-op, we want to evaluate for a VSD to make sure that we didn't cut all the way through or cause some other problem to these patients. But what might happen is you may see something like this on the right-hand side. And, you know, at first look, this may look suspicious for a VSD, but then when we pause it and really look at the timing of it, it is in diastole. And what that is actually coronary flow, and it's a septal perforator. And what happens sometimes is the surgeon cuts into that piece of tissue and cuts part of the coronary artery, and that's a normal variant in these patients post myectomy. The other HCM treatment is doing an alcohol septal ablation. And so these are done in the cath lab, and you really have to have an interventionalist who is pretty experienced with doing these because they're tricky. And so the first thing that we do is we do it echo guided here at Northwestern Memorial Hospital. And so I like to first get a baseline image to see where the obstruction is. And we can see that there's SAM, there's even a little scar here from where she's been SAMing so much. But then also to make sure I can get this same image as we're optimizing where we're going to do this ablation. So when we do it, I like to use some echo enhancing agents, usually Optison, but this is an off-label use for those agents, just to make a note of that. But what we'll do is the interventionalist will look at the coronary mapping and look at where those septal perforators are and see which branch feeds that basal septum. And we can do that by injecting Optison or another contrast agent right into the coronary arteries. So in this first injection, we can see this mid-septum light up, and it's really transmural. And so if that, if they were to ablate this area and put alcohol in there, it may cause a VSD and also infarct the wrong part of the heart. On the second Optison injection, we really localized that and were able to find it right at the basal septum. And we can see even in the cath lab, we dropped the gradient from a baseline of 57 to 33. And something I'll just bring up is these patients, because we're ablating that and giving them this controlled heart attack, that area may be inflamed for a little bit after HOCM. So their discharge echo, they may still have what looks like obstruction, but about 3 months follow-up, they should be about back to normal, where you can actually see results of this alcohol ablation. And finally, my last case is a 69-year-old female who presents with progressive DOE, and we started her on Norpace therapy for her provocable LVOT obstruction. And so we can see at baseline it was 16, it was provocable with Valsalva up to 41, and then with stress echo had a peak gradient of 84 out of that LVOT. And as symptomatic as she was, we wanted to start therapy for her. The Norpace didn't work, and so we went to an alcohol septal ablation. Again, these patients are lying flat on the cath lab table, so some of these images are not the greatest, and so you really have to have an experienced sonographer to go in and do this as well. On the first Optison injection, we see still that transmural, kind of like that example I gave. So this would not be an optimal place to ablate. But then in our second injection, we can see it's just at the basal septum. And so we ablated, and she did pretty well. But then she came back 3 months later at her local hospital and having some more shortness of breath. And we were able to get some of the echo images. I saw that there was a baseline gradient of 23, and then the recorded Valsalva gradient was 73. But I'm curious to see what my panel has to say about some of these gradients here. When I look at this 2D image with the color, I'm not seeing as turbulent a flow around that basal septum as I would think so, and that is confirmed by our LVOT. I'm not seeing that aliasing like we would expect if there was for sure obstruction. And I'm noticing some increased flow through the mitral valve as well. So they referred her back to try another branch of her septal perforator to see if we could get that septum down a little more. But while she was in the cath lab, we did just a resting gradient. She only had a baseline. And because they're only under MAC, Hcm and Valsalva, and it only went up to 31. On 2D echo, I wasn't seeing that obstruction and where that SAM was. And again, confirmed by this pulse wave Doppler. And so what I thought it probably was is maybe we had been picking up mitral regurgitation in that continuous wave jet and kind of falsely gave her this really high provocable gradient, when really maybe her DOE is coming from this high mitral valve gradient. So she is now being worked up for some mitral valve therapies. So I'll quickly go through some mimickers of HCM. Some hypertension and aortic stenosis are afterload increasing conditions, so can really bulk up that hypertrophy. Athletic hearts can look a little thicker and also larger than normal, so it might kind of guide your eye to some genetic disorder. With amyloidosis, we see a thickening and kind of still fibrosis of the myocardium. But then with these, we can see the strain pattern is that apical sparing and not the just septal decreased strain as with the HCM patients. LV non-compaction can also be a little confusing because there's focal hypertrophy in places that we don't expect it to. Storage diseases such as Fabry's disease can also mimic this disease and is also genetic. And then finally, I wanted to just show this image of a dobutamine stress echo and this hypercontractility that provoked obstruction, but there is no HCM. So in summary, some of the crucial echo findings that we need to pay attention to are the hypertrophy, where it is and how severe it is, and also the obstruction, where it is and how severe it is. And those two things we really want to make sure to put into the report for our clinicians to read over. Any secondary findings such as mitral regurgitation or apical aneurysms should also be noted. And then finally, our therapies for hypertrophic cardiomyopathy, besides medical management, some of the invasive therapies are the ASA and the surgical myectomy. And when you're looking at a patient that has something that looks like HCM, really look into their history, because you really may be able to find some clues as to if it's actually HCM or another disease. Here's just a slide for some continued reading on some guidelines about HCM. And thank you so much. And I'll stop my share so that we can have some discussion.
Thank you so much for that wonderful presentation and all your helpful hints. It's very fantastic. You did an excellent job. You know, you really stressed the basics and the importance of accurate measurements. And I wanted to ask our expert, Dr. Phelan, what is your advice on how to measure and where to measure? Are there certain views that we should really measure in? And any helpful hints that you can give the sonographers that are on?
Yeah, I agree with you, Lucy. Madeline, that was a tour de force, just a great talk. Madeline and I worked together in Cleveland Clinic previously, so we got similar training. And really the emphasis is on making sure that those measurements are accurate. You're absolutely right, and it's something that is so important for these patients, because, you know, a lot of the things that we do, we're trying to make a diagnosis, as Madeline pointed out, a diagnosis of greater than 15 millimeters without other causes will make the diagnosis of HCM, but we're also using hypertrophy or description of hypertrophy to define risk. So if people have massive hypertrophy, there are people that are at higher risk for sudden death, and we're going to put in an ICD in those individuals. And we also need to be able to guide our surgeons and interventionalists for septal reduction therapy. So defining accurately the degree of hypertrophy and location of hypertrophy is key. Echo does a very nice job for most segments. I think the areas that Madeline pointed out that are probably the area that causes the most trouble is the septum. And really the key here is to make sure we're cross-referencing images. So looking at that short axis image, looking at that long axis image, sometimes it's very difficult to differentiate what's compacted LV septum and what's RV trabeculation, or that crista supraventricularis that comes in there onto the septum that can really fool us and way overestimate the degree of septal hypertrophy. And that's where, you know, cross-referencing will really help with that. You know, there are segments, the anterior wall can be challenging to see on echo. The apex, you know, clearly we always emphasize the need to not foreshorten our apical views. But even with the best will in the world, sometimes we do that. And so there are times where we will not be able to see all the walls perfectly. And I think that that's where, as an echo imager, we need to recognize the beneficial and how we can use cardiac MRI as an adjunct and a helpful adjunct to our echo imaging in people who we've got a high level of suspicion that they have hypertrophy or our echo images are not perfect.
Excellent, absolutely. And you know, for your apical variants, Dr. Masari, what do you do? Do you use contrast often? Is it standard that you use it for all of your apical variants of hypertrophy, or just in the ones that you're concerned for that there could be possibly an aneurysm there?
First of all, fantastic talk, Madeline. Yeah, I mean, you know, it's one of the exceptions in our echo lab where our sonographers know if there is, even if it's a non-apical HCM, that they have to use contrast. The reason is not for the diagnosis. The reason is rather because when we do follow-up imaging, it's actually to look for the development of an aneurysm, early aneurysm, as well as to look for thrombi hiding in the you know, trabeculations and in the thick apex. And so we do use contrast in almost everybody with apical HCM, even if the non-contrasted pictures appear to be reasonable.
Yeah, I would agree with that. And I think even, you know, the mid-cavity patients, the patients who have mid-cavity obstruction as well, a little bit like the Madeline showed in that case, they're people also that develop, you know, this big obstruction at the apex. They develop that oxygen supply demand mismatch. because of the pressure buildup at the apex, and they're the people who kind of get that ischemia and end up getting the aneurysm. So I completely agree, Ahmed, that we really emphasize liberal use of contrast, and really probably all patients with mid obstruction and apical HCM should get contrast. And again, emphasizing what Maddie showed, which is that kind of off-axis imaging of the apex, really, really effective in identifying those apical aneurysms.
Yeah, absolutely. I think her imaging in those examples that she gave where she went down a rib space really was a great example of how to really sweep and try to make sure that there's nothing that you're missing in these very complicated patients. And gradients are really, I think, one of the most challenging things in hypertrophic cardiomyopathy, and you showed a great example of how you can use PW to really locate these areas of turbulence and obstruction. Dr. Phelan, in your lab, is that how you standard go through the gradients in your lab? Is that how they're obtained? And can you walk us through how it's done there?
Yeah, I mean, I spoke to Madeline about this before, and all of the guidelines recommend marching out with pulse wave Doppler. I think that that's generally an accepted standard to do that. I actually personally think color Doppler really identifies the location of flow acceleration in most cases. And what I emphasize more is putting a full color box throughout the LV when we're trying to see this. And you could see in that beautiful example that Madeline showed, where she just marched back and forward, you can really see where the flow acceleration is throughout the whole LV, as opposed to just putting multiple sample volumes throughout. That's more time consuming, doing the pulse wave Doppler. I'm sure that's controversial. I don't know what Ahmed would say to that, but my personal feeling is, so long as we get a good color Doppler throughout the LV, I can tell then where the flow acceleration is occurring. Now, where that's really important is where you've got multiple levels of obstruction. And when you've got the LVOT obstruction with the aortic stenosis and so on. So that's where you really need to use pulse wave Doppler to try and identify where the main flow acceleration is. But my own feeling is color flow Doppler gives us most of the information.
Mm-hmm.
So I agree with you, and it does take time, and sometimes it's probably more helpful when you have also like mid-ventricular gradient. I think one of the major issues we see in the community is very few people differentiate LVOT obstruction from mid-ventricular increased gradient or increased velocity, and everybody just reported as LVOT gradient is X. And I think that's where this following the step up sometimes help, especially for in labs where they don't see a lot of HCM. It does help differentiate that, because as we know, the treatment is kind of different really if there is no LVOT obstruction whatsoever. And we emphasize that to our fellows all the time, but I agree with you, with color you're going to be able to tell where it is. And the second point is we get a lot of referrals where the 2D echo images just show a gradient, but you can't see anything on 2D. And I think, I don't know what Dermot or Lucy do, but, we don't accept typically just agreeing on the gradient and moving on. We typically end up doing TEE sometimes if they can't get other types of imaging because you need to look at where the obstruction is, what's the level of the obstruction, and what the anatomy is.
So important, such important points made there. And I think the point I was making with the color box is really that will locate where the obstruction is. So if you do it by pulse wave, color, 2D visually imaging it, whatever method you use, you have to identify where the location of obstruction is, and that has to go on the report. I couldn't agree more. It's frustrating when you see images where it's just a continuous wave Doppler, and this, where the biggest mistake is often made, is with Valsalva or post-exercise. So just the continuous wave Doppler is put down there, and you don't know if that's coming from mid-cavity, you don't know if it's coming from LVOT, is it SAM related? And the management changes dramatically depending on where that is arising from. So what we do, what I recommend doing is actually using the color compare. So you've got the color, you've got a 2D image. You know, when you're doing the Valsalva, you use color compare, so we can see, is it coming from mid-cavity? Do we see the mitral valve moving over on 2D? Do we see where the flow acceleration is? Visualizing it first, and then doing your continuous wave Doppler to quantify the degree of obstruction. So we have to identify the level and the severity of obstruction.
That's actually very helpful too for assessing the degree of regurgitation. So SAM-related mitral regurgitation. So, you know, in color compare, again, if a patient is able to Valsalva and you're able to see an increase, I think, again, Madeline had a great example of severe MR with Valsalva in her presentation. And again, color compare is very helpful for those situations. You know, determining mitral regurgitation is difficult, especially when, you know, everything blends together and you don't quite get a great PISA. What do you do in order to help quantify MR in these cases?
Yeah, that can be very challenging for the reason you've just mentioned, and oftentimes it is, as Madeline described, it's as that mitral valve is moving towards the septum. There's the separation of the anterior leaflet, and you get a gush of mitral regurgitation. So it's not holosystolic, it's late systolic mitral regurgitation also. So a lot of our quantification techniques kind of go out the window for a multitude of reasons, and really we often end up using more of a semi-quantitative assessment of MR, visually assessing the degree of color flow Doppler there. And you know, you can obviously use pulse wave in the pulmonary veins and things like that, but that's not the priority when you're doing Valsalva maneuvers and things like that. So generally in our reports, we comment on a baseline resting MR. I think it's really important to comment not only on the degree, but on the direction of MR. So clearly that SAM MR is usually posteriorly directed. And most of the time by relieving the obstruction with whatever technique you use, either medical therapy or septal reduction therapy, that mitral regurgitation will go away. If it's central or if it's anterior mitral regurgitation, the traditional teaching was that that's probably more intrinsic valve disease. Now, Mayo Clinic published a paper a number of years ago showing that that's not necessarily the case, that depending if you've got a very long posterior leaflet or a very short posterior leaflet, you can get central or anteriorly directed MR. But really, from the purposes of the sonographer, I think if you don't see that posterior MR, really need to look at that mitral valve very closely. Is there prolapse? Is there fail? Is there some other mitral valve disease? But I think, you know, the mitral regurgitation, both the assessment in terms of its quantification and cause is really key to a good echo in patients with HCM.
Thank you for that. I wanted to pivot. There was a question that came in through the Q&A box. And again, I want to encourage all members who are watching to enter in questions. Is the diastolic pattern of hypertrophic cardiomyopathy progressive, or is it related to the severity of the disease?
So you can, I'm not sure, I just want to make sure I understand the question being asked. So I guess you can get all the grades of diastolic dysfunction in patients with hypertrophic cardiomyopathy. You know, the traditional teaching was that people with hypertrophic cardiomyopathy always had bad diastolic function. We know now when we look at athletes that have hypertrophic cardiomyopathy, often the measured parameters of diastolic function can look completely normal. And you can go from normal to profoundly restrictive. And that can be unrelated to the degree of hypertrophy. So you can get people who've got extensive, it's more often related to the degree of scar tissue that we see on MRI, but certainly you can get all grades of diastolic dysfunction in hypertrophic cardiomyopathy. Our traditional markers of diastolic dysfunction are not as reliable in patients with HCM as they are in the general population, but we can certainly still evaluate it. I'm not sure if I understand the question properly, if that answers the question. Interested, Ahmed, have you any other take on that?
I'm wondering if, you know, if whoever asked that question is referring to the relationship to the gradient. What's your take on this from a diastolic function parameters and the relationship to gradients, you know, meaning someone has a gradient of 50 versus someone has a gradient of 100, 150. I know that this does come up, that, you know, people relate the severity of HCM to the number of the gradient. What are your thoughts about this?
Yeah, I mean, when you're getting into gradients of 100 millimeters of mercury, you know, I think you've got a good assessment of why the patient is symptomatic in that case. And I think it can become a little bit more challenging to evaluate diastolic function as you elevate the LV filling pressures, more related to the outflow tract obstruction than related to intrinsic stiffening of the LV, which you normally assess.
Yes, absolutely. You know, I completely agree with you. I think part of the challenge actually of HCM and why it's fun, because of the dynamic nature of the problem, but two, because you have so many different hemodynamic classes essentially overlapping at the same time, and some of the mutations are more pro-fibrotic and pro-restrictive in a way, especially of the atria compared to others. You know, all great points there.
I wanted to pivot to treatment. There was a question that came in. I think it was related to the second case that was presented, but in terms of post-myomectomy initially, I know that we mentioned that VSDs are a concern. Are there anything else that we should be screening for after a myomectomy in patients on echo?
Yeah, I mean, obviously in the immediate post-operative phase, you're looking for the general post-operative complications that you might see, like pericardial effusions. Obviously, unique to the myectomy is the not unique, but specific to myectomy, I should say, is the creation of a VSD. Those coronary artery fistulas that Madeline showed showed really are not of any hemodynamic significance. They're not a worry. They're just good for giving the fellows a hard time when they see those flows first and don't know what it is. So I think it's important to recognize that that's diastolic flow into the LV. And when you see that post myectomy, it's not of any concern. Obviously, VSD is usually systolic out into the RV. You know, these are usually done via the aortic valve. So we'll look at the aortic valve and make sure there isn't a significant increase in AI, although that's extremely rare. And we'll look at the aorta to make sure that's attacked like we would normally post open heart surgery. And obviously then we want to see, is it effective? So what's the gradient? Is the gradient still there at rest? And is it still there with provocation? So they're the main things we'd be looking at. Anything I missed there, guys? Lucy or Ahmed?
I think gradients is very important because in surgery, you know, it's done with TE and they're under anesthesia. So, you know, when the patient wakes up and they're at normal, you know, blood pressure, you know, the gradients can definitely change.
Although important in surgery to provoke, you know, before you take the patient off the table, using isopril, dobutamine, or some agent to try and make it as bad as possible while they're still on the table, so they can go back in and make adjustments as needed, is key, because you don't want to provoke them afterwards and realize they have no resting gradient, but you know, they're still getting provoked gradient.
It's very great advice, especially for the cardiac anesthesiologists that are listening.
That's a great point. And the other point is, you know, we actually do provoke all of our patients intra-op, pre and post, because the majority of the time, you know, any residual MR or gradient is actually just provoked. It's not at rest. There is nothing. But the second point is in our insurance market, even pre-surgical intervention or even myectomy, they typically try to deny exercise echo if you have a resting gradient above 50. Personally, I think it's actually very helpful to understand how far can this gradient go and how really bad the gradient is and how, you know, symptomatic the patient is with exercise. And so that essentially relates to the same theory is, you know, you want to understand under stress and under, you know, this condition, what does the heart do? Similarly, after your intervention or during it, if it's myectomy, you also want to understand, you know, what did you relieve and what's the maximum benefit there?
Mm-hmm. You know, I want to ask a very similar questions in terms of, we talked about myectomy, but what about alcohol septal ablation? What are some of the things that we look for in echo, either during the procedure and immediately post-op, in order to look for both procedural success and complications?
Yeah, I think Maddie beautifully described the pre-procedural issues, and I think the biggest one is making sure that it's the correct septal perforator, or that the septal perforator is only feeding that area of hypertrophy in the septum and not extending into the RV in particular. So I think that is really the most important thing in that pre-assessment, and getting those gradients at the start. And as Madeline pointed out, it can be really tough when the patient is, you know, lying flat in the cath lab. You really need to be a sonographer of Madeline's caliber to be able to get those kind of quality images. You know, after the procedure, I think, again, to emphasize what Madeline said, don't be fooled by high gradients. You know, after you've done the procedure in the few days before discharge, you'll often get an echo before discharge and get a phone call, oh, it didn't work. You know, the gradients are back. And so that's actually just the edema that occurs peri-infarct. And so often the patient can have significant outflow tract obstruction, that kind of pre-discharge echo that will resolve after a few months. And so you just kind of have to wait it out over that period of time, and then that will improve.
When do you bring the patients back for secondary imaging?
Usually about 3 months.
Mm-hmm. Dr. Masari, do you do similarly, or?
Yeah, we actually follow up everybody essentially in the same fashion. So we do an echo. We don't do an echo pre-discharge. We do an echo at 1 month in the clinic when we see them, and then we exercise them if there are any residual symptoms or any problems. We exercise them at about 3 to 4 months time. You know, that where we would be expect to have the, you know, the highest benefit there. And, you know, that 1 month follow-up is just, you know, we standardize it for both myectomy and for alcohol septal ablation.
Mm-hmm. A question came in through the Q&A line. What do you think are the major pitfalls in assessing gradients in critical care patients?
Yeah, so I think this question gets to the fact that not all SAM and LVOT obstruction is HCM. And so we will see this frequently in the critical care, well, not frequently, but not infrequently in critical care patients where they may be profoundly anemic or hypovolemic. If patients have a Takasubu cardiomyopathy, if you know, and many other reasons that you can get LVOT obstruction that is not related to HCM specifically. And so, you know, I think the major pitfalls in assessing the gradients in the critical care patient is really down to the difficulty in imaging these people. The fact that they're intubated, they're on their backs, they've got multiple tubes and so on. It just can be very tough from a sonographer perspective. But it is important to document from a management perspective, because obviously some of these, the management may change dramatically if you do have that. Someone may need an additional volume, they may need blood, they may need beta blockade in someone who's got, you know, a Takasubu cardiomyopathy, for example. So sometimes we end up having to do a TEE in these cases to properly assess that.
Mm-hmm. to make sure it's not one of the mimickers and it's truly hypertrophic cardiomyopathy. I just wanted to ask a quick question on strain imaging. And I know that you've done a lot of work on strain in the past. What are some of the things that you see in terms of strain for patients with hypertrophic cardiomyopathy?
Yeah, it's a really good question. We certainly see a reduction in strain. I think the first studies using strain in HCM kind of came out in around 2005, 2006, and so it's we've got about 15 years of data here, and unfortunately, it still hasn't gotten to the point where it's something that we use on a clinical basis on a day-to-day basis. We can use strain goes down when you get significant hypertrophy, and strain will go down when you've got fibrosis. So on even autopsy and CMR studies, you correlate those back to the echo images, we see that strain goes down for those two reasons. So in Maddie's example, she showed an apical HCM where you've got all the hypertrophy at the apex and you've got fibrosis there. Your strain goes down at the apex in those individuals, looks like an LAD infarct. For people who've got septal hypertrophy, the strain goes down at the septum there. But it's hasn't been used as a means of diagnosis, unlike where we can use cardiac amyloid, where it's got good sensitivity and specificity to diagnose cardiac amyloid. It doesn't have the same degree of sensitivity and specificity for HCM. It certainly is prognostic. Study after study has shown that the reduction in strain will predict worse outcomes and ICD discharges and sudden death and so on. The problem is that all of these studies, they tend to be single center, small studies. They use a variety of threshold cutoffs to define what risk is. And so trying to put all of those studies together for us to say, if strain is X, then the risk is high enough for them to warrant an ICD, we're not there. We just don't have that data. The last thing, which is still kind of in research, is trying to identify those people who have genotype positive but phenotype negative. Are there patterns on strain in those individuals that will predict the people who will go on to develop the disease? Again, lots of small papers out there, not a consensus on that either. Multiple studies have shown that there perhaps is a regional reduction in strain at the septum in those that we would consider phenotypically negative. But again,